This program is brought to you by Emory University.
Good morning, everyone. We're going to go ahead and get started. First of all, I just want to congratulate the structural heart team. Many of you were at the big event Saturday night, which was fantastic, the 1000th TAVR celebration. I guess there were, Robert, 400 people there or more? I mean, it was quite an event and really a great celebration. And so congratulations to the TAVR team, our team, both on the cardiac and the surgery side. It was really a special night, and just special congratulations to them. Today we have a special treat too as well. We have Herman Taylor. Many of you know Herman. He I guess did his medical training in Boston and Harvard, and has wandered through a variety of places like most of us have, but has really made his name as an cardiovascular epidemiologist, and has been involved in many of the large studies that we're familiar with, and most notably the one that he's really had the major leadership role in has been the Jackson Heart Study. He's going to talk a little bit about that today. And Herman's had, again, a lifelong interest in cardiovascular epidemiology and focused on disparities and developed the Jackson Heart Group as really a really interesting cohort that's really been very helpful in informing us. Herman took on a new challenge last year. He came to Morehouse to head up the Cardiovascular Research Institute there, where he's the director and holds an endowed chair. We are also fortunate that Herman is an adjunct professor here in the Division of Cardiology, and we started building some bridges, working on some collaborative projects, and we're hoping those will continue. And today he's going to talk to us about race, risk, resilience, and early insights from Jackson. Welcome, Herman. It's great to have you here.
Thank you very much, Robert. And good morning, everyone. Good Monday morning. I hope you all have had your coffee. We will take a brief tour today through the Jackson Heart Study. And as this is an introduction, you will not be overwhelmed by a lot of data this morning. I will sprinkle some through the talk. However, I want to really help you get to know the Jackson Heart Study, to contextualize it, and perhaps with that background information, begin to delve into some of the data that's emerging from this study that has been up and running for a while now. Just use this. Okay. All right. First, a little background. Jackson is in Mississippi, and Mississippi is a surprising state. And so let me just remind you of some of those surprises that come out of that humble part of the United States of America. Now, this is a typical scene out of the Delta, where you see a flat, desolate appearing field, and at a glance, you wouldn't begin to expect that in just a few weeks past this particular photograph, that the field would burst forth with all of this life, and with soybeans, wheat, even cotton, and to such a level of abundance that it feeds and clothes millions of people in the United States and also in other places around the world. Also surprising, perhaps, out of Mississippi, people are very familiar with its turbulent past, particularly when it comes to racial strife. But the same place that's the source of pictures like this also produced these authors, these people who have expressed to a level of depth that is unusual for any part of the country, but particularly coming out of Mississippi, we have major authors. Some of you may recognize Richard Wright, Mary Alexander Walker, Eudora Welty, Percy Faulkner, and the list really could get a lot longer than that. A place also that gave rise to people who dedicated their lives to racial reconciliation out of this crucible, if you will, of racial strife. Also, it may be surprising that a place that is often thought of as the epicenter of the cardiovascular epidemic, and unfortunately rightly so, has given rise to people who have contributed mightily, including Dr. Guyton up in the right-hand corner, to the resolution, if you will, of some of the things that plague not just Mississippi, but the United States in general. And one thing that's emerged out of Mississippi, out of this environment, is the Jackson Heart Study. We're going to talk a little bit about that. It is a response to an interesting set of circumstances. Here we see illustrated something you're all familiar with, the fairly dramatic improvement of in cardiovascular disease mortality. Over the last half of the 20th century, there's been an over 40% drop in cardiovascular disease death rates in the United States. And this particular slide, taken from Betsy Nabel and Eugene Brownwall's article a few years ago now in the New England Journal, arrays along the curve some of the major developments that have at least in part contributed to this fairly dramatic public health success. Unfortunately, simultaneous with that, we have these trends. Bucking that national trend that's been documented for 4 or 5 decades, we see that in a measure that's as important as first myocardial infarction, that while the trend is downward for white men and white women, the trend is generally upward for African Americans. And those trends are significant, although you see the slope may not be impressive at a glance. It's still in the wrong direction and statistically significant. These data are taken from the ERIC study, of which the Jackson Heart Study in part was born. And these are data from 4 cities across America, all compiled to show that this trend is real and disturbing. And it contributes to data like these. So this looks at black men in Mississippi, arguably a worst case scenario for cardiovascular disease mortality in the United States. And you can see that, and I'll point here, that while this trend has generally come down, and because it is a small state, you see that the point estimate is a little unstable. So the curve bounces around a little bit. And if you were to extend on out to 2015, you'd see also a continued sort of downward trend. But the gap has not narrowed. And at least as of the early part of the 21st century, you could see another disturbing fact. And that is, if you look at 1976 approximately, and say that this is about 900, and you come over to 2003, you can see that there's no real material gain for that group of men in the United States. Similarly distressing data obtained among women, suggesting again that there's a huge gap. It's not narrowing nearly as quickly as any of us would like. So the Jackson Heart Study was born of a concern about these types of observations. Most people think of it as a study that's the black Framingham, the Framingham of the South. Actually, 2 very flattering descriptors because of the great contributions that Framingham has made. And there are other parallels with Framingham that I'll just take a minute to point out. If you look at Framingham and who's in it and where it is, all right, at a glance, you would say, wow, this is a very restricted population. All of the members of Framingham, almost all of them, of that original cohort, were either Irish American, Italian American, or Irish Italian American, right? They were all in this one little town outside of Boston, one little New England town. So at a glance you say, wow, that's data that couldn't possibly be generalizable. I mean, if you really look at it objectively. But what's the objective truth? What we've discovered over the years, over the decades, is that a well-done study, even though it is somewhat restricted geographically and maybe even ethnically, has produced lessons for the world, has given us paradigms to look at disease patterns, to understand cardiovascular risk in just about every country. Now, it's not exact on the money for prediction in every single circumstance, but the trends are reliable, and reliably we see everywhere we go that Framingham does a fairly good job of predicting cardiovascular outcomes, although imperfect, still remarkable at how global the application has become. My point, though, is simply this. Sometimes the Jackson Heart Study is looked at as, well, that's a study in a small town in the United States of America. How generalizable can it be? I would urge you to keep an open mind as you look at the data and look for the lessons that might be more globally or generally applicable. So, similar to the Framingham Heart Study, a large community-based observational study, actually a little bit larger than the original Framingham study. Our recruiters were determined that they would recruit more than the original 5,209 people in Framingham. We actually recruited 5,301, so we won. But it's a large community-based observational study. It actually represents about 6.6% of all the African Americans in the age range that we were targeting originally in the three-county area where it's based. It included examinations and interviews, and we call these visits. And in between visits, there was surveillance. We had the great circumstance of there being 8 main hospitals in the area, in the Tri-County Metropolitan Statistical Area. And we have relationships with all of those. So we have information on our participants when they go in and come out of the hospital. So it's a fairly comprehensive long-term surveillance, even though the last examination ended in 2013. Okay, comprehensive. All of this and more was obtained at baseline. So you see fairly standard studies on the left, such as blood pressure, sitting, ambulatory, 24-hour. Not everyone did the 24-hour ambulatory blood pressure monitoring. About 1,200 individuals wound up completing that. Echocardiography on well over 4,600 people, electrocardiography on just about everyone, carotid ultrasound at baseline as well, and then these other things, physical activity monitoring, pulmonary function, urine collection. Again, we have 24-hour here, but again, only about 1,100 or so, 24 hours, but everybody just about gave us spot urines, and a lot of bloodletting, as you can see here. And the great thing about that is not only what we're able to determine as a first pass with analysis of blood, but there are many aliquots of stored blood available from baseline. And baseline was 2000 to 2004. And we repeated it. Now, here's the amazing thing about the repetition of the visits. That first visit, after we had spent a year and a half haggling over what things should be in a baseline visit of a study of this scale, focused in an all African American population. Everybody had their favorite question or their favorite test or their favorite instrument that they wanted to include in the protocol. So, we started out with basically a 10-hour visit. Nobody is going to sit still, obviously, for over an entire workday. We gradually whittled the individual visit for the participants down to about 5 hours. 5 hours. So we were very concerned that after we went through that first round of visits, that nobody would come back. 5 hours is a long time to be poked, prodded, and questioned for anyone. But exam 2, which was essentially, intentionally kept somewhat light compared to exam 1, is the high points are seen here. Probably the big feature was the CT scanning for abdominal fat and coronary artery calcium that took place in that exam. And MRI as a pilot was done then. And then 3 years later, approximately, we went back to the heavy form of data gathering for the Jackson Heart Study. I just put this up because I wanted to have one motion picture in the presentation, but it also shows you that the Jackson Heart Study is comprehensive in many ways. So we had a lot of blood drawn, we have a lot of blood stored, and we have some fairly high-tech data and imaging available on a large, in this case minority, but a large segment. And this represents some of the largest collections of this type of data in a free living population that you'll find anywhere. These are not patients, these are free living individuals. Some have disease, most don't. And we have data to look at the average, if you will, African American. So one thing then, the title said early lessons from the Jackson Heart Study. And there's one lesson that we cannot rush past. And it doesn't, again, involve a lot of hard data, but I put up there the speed of trust. If you're going to do a study, an all African American study in the South, sponsored by the government, does that ring a bell for anyone? Okay, I can tell from the chuckles that I think you all know where I'm going with that. And it rang a bell for a lot of people. And in the pre-recruitment survey, in one of the pre-recruitment surveys, you can see that we were facing a little bit of a problem in that if you look at these responses to the various questions, in general, medical research treats people fairly. Only a small majority agreed. A very large minority had questions about that. People put themselves at risk if they participate in medical research. A third of the potential age range appropriate people that were interviewed said, yeah, I think so. Medical research is too hard for people like me to understand. Medical research is a black box, then probably best to be avoided. That was a common sentiment as well. And somewhat unfortunate, but not a lunatic fringe, this is 14% of people, said that medical research is a way for the government to keep black people down. Now, this is 1998, and some interesting things that happened in 1998. For one thing, the whole Tuskegee study controversy was brought back to the fore. A lot of you are too young to remember this, clearly, I'm sure. But you all have heard of the Tuskegee study. I took that from the chuckles I heard. An egregious breach of trust that occurred in an all-black study in a small town in the South, sponsored by the federal government. That, I think, set up a lot of issues. And in 1998 was a particularly important year because it was that year that President Clinton apologized for the Tuskegee study, which of course brought it back to everyone's consciousness. And we were about to go out and recruit. So the timing, I mean, it was absolutely the right thing to do. The timing could have been better for us as recruiters. Furthermore, there was a movie called Miss Evers' Boys, Alfred Woodard and Lawrence Fishburne, if you want to know the stars, that was available on HBO, that was put on HBO and available, you can get it today on DVD, that dramatized the whole Tuskegee episode. And all of that, I think, fed into some of this, and particularly concerns about this. And here's some news clips from around the time. New York Times talking about syphilis victims in the U.S. study went untreated for 40 years. And here was a recruitment brochure for the Tuskegee study. Free blood test, colored people, it says. Do you have bad blood? Free blood test, free treatment. Seems like a good deal if you're worried that your blood is not quite right. But unfortunately, it turned out to be a major breach of trust. So in order to speed up trust, if you will, one of the most important things we did was involve the community from day one, not only in surveys and talking to folks, trying to hear from them what they were most concerned about in terms of their heart health. They also advised us in some very concrete ways about how to go about engaging people. And one of the most important steps was to look to others who had participated in research previously, who had had a good experience and had good things to report and believed in research as a major way forward for African American health. Everyone was concerned about the state of African American health. They had to be convinced that this was a legitimate, trustworthy, and fruitful path to pursue. Another major thing that we did in parallel with the Jackson Heart Study, we invested in young people. Now, these are graduates of our Jackson Heart Study Scholars Program, and they were all students at Tougaloo College, but there was also a high school part of this too. So obviously this was expensive, But that investment in the community on several levels, I think, led to a level of trust that really facilitated our further involvement with the community. So right now, if you go to Jackson, Jackson Heart Study is a household word. People trust it, and they look to it to continue to give information about their own health and contribute to the general health of Americans. I think that's a fairly common sentiment now. But it took work, it took time, it wasn't fast. And the continued involvement of the community in things like the steering committee, even the publications committee. We have lay people on those committees. Again, that's not a fast way to do science when you have to stop and explain why you are investigating this particular aspect of health, why you need DNA, what's going to happen there, what is RNA, what is DNA really. When you're stopping and explaining some of these things along the way and trying to contextualize it, it does not, again, facilitate rapid production of science. But in the long run, once the trust has been established, you can accomplish a lot more, and you keep the community engaged. Retention is the key to these longitudinal studies, keeping people involved and getting data over the long haul. And you need trust for that. You need trust for recruitment and for retention. So, in the end, 5,301 African American men and women aged 21 and older. Exam 2, the one we were worried about, would anybody come back? 85% of the survivors came back, and again, about 80% came back on the third exam. So, now here's some data. Some selected insights on risk factors. First, because we were so frequently compared with the Framingham Heart Study, we just embraced that. And so let's compare ourselves to the Framingham Study in some basic ways. So looking at the issue of obesity, all of you who take care of large patient panels, and that include a lot of African Americans, can probably appreciate that obesity is a problem in among African Americans. And this just dramatically shows that as well. So in the normal range, you have 3 times as many whites from Framingham as you do blacks from Jackson. And in the stage 2 obesity range, you have 3 times as many blacks as you do whites of comparable age, etc. So I don't think that, as dramatic and unfortunate as that is that much of a surprise. It may be more surprising, perhaps, if you look at blacks with normal BMI, compare them to whites from Framingham with normal BMI, and still you see a dramatic disparity. If you look at diabetes rates, they're 2.5 to 3 times higher. This is prevalence. Hypertension, similar to that. Everything except the triglycerides. African Americans actually had worse profiles, even though they looked in terms of BMI, like the white counterparts in Framingham. Another interesting finding came out of the comparison that if you look at obesity-related risk factors, if obesity is expected to give people a more negative profile in terms of their cardiometabolic risk, it was interesting to note that the trend was that if you compared obese whites and obese blacks, that as you go up the gradient of obesity, it seems that the negative impact on cardiovascular risk factors was much more prominent among whites in Framingham than blacks in Jackson. And this squares with some other data that would suggest, and I have to be careful here, that obesity somehow is perhaps more, as measured by BMI, perhaps more toxic in whites than blacks. Now, I say that very carefully because if you start looking at population attributable risk, obesity has a much greater impact in the African American population. But these data are interesting to suggest that as you go up that gradient, the impact of obesity seems to be more profound in the white ethnic group. This is interesting mainly because of the historical notion that African Americans have notoriously poor control of their blood pressure. And there's even data, even the latest data from NHANES would suggest that there's a huge difference between control in black hypertensive versus control in white. What we found counter to that in the Jackson Heart Study was that control rates, as we measured them, were in African Americans looked like the control rates in whites in NHANES. And we were happy about that finding, but of course it was questioned. And while there's not an exact direct comparison in every way between NHANES and Jackson, what we can say are these sort of general things about why that might be. Why might blacks in Jackson have very good control? None of us thinks that that 70% control is very good, but let's take that as a national standard, and that's really a little bit better than you see in NHANES for whites. The Jackson Heart Study was different in several ways from sort of standard studies in African Americans. Very often, the data you see presented on African Americans tends to be data on poor African Americans from the lower socioeconomic strata. That's just a historical fact. Even NHANES has a slight overrepresentation of poor African Americans. The Jackson Heart Study had about a quarter of its participants who did not complete high school. It had about a third of them, however, who had some college or completed college, and the rest were in between. So this was relative to a lot of studies that are presented as representing African American data. Our study was perhaps a little bit more consciously representative of a broader swath of African American society. Again, all in Jackson, all in the South, but the socioeconomic spread was significantly higher than you see in a lot of studies that get reported. So that piece probably contributed. Also, in the Jackson area, you have a strong history of focus on hypertension. Herbert Langford was there and trained most of the physicians in town. Dan Jones followed him. There has been a high level of awareness and focus on the local practice community. So all of that could be a part of that. But this was encouraging and shows that what is possible in a group of African Americans, that rates can be achieved that are comparable to whites nationally. We spent a lot of time on social backdrop here, and that's important for us to keep in mind. I think all of us recognize that the African American experience, as it is often called, is a unique one, and some of the social determinants or social circumstances can be challenging to the physiology, if you will. And there's been a substantial investment of investigators of the Jackson Heart Study data in looking for social determinants of health. And this just shows some of the papers, and there are many more. Dr. Sims of the Jackson Heart Study looked specifically sort of right at the issue of discrimination. Now, this discrimination here is not just on a racial basis. It's also about height and weight and gender, but looking at subjectively perceived unfair treatment, he found that it was associated clearly with high blood pressure. Perhaps not a surprise, but documented in a longitudinal population-based study is an important step towards establishing that as a real thing. Looking at the phenomenon of nocturnal dipping in African Americans, again, thinking about socioeconomic position as being an important factor in health. Again, not an alien concept, but here we have some fairly hard data suggesting that the more money you have, the more likely you're going to have the physiologic dip at night and avoid some of the negative consequences of blunted nocturnal blood pressure dipping. So you can see the spread here. The highest household median income was associated with the deepest dip at night. And the Jackson Heart study, usually in collaboration with other studies, has published extensively in the genetics sphere, and from everything from looking at genes that are tied to ethnic neutropenia to some things that are more centrally focused on cardiovascular disease. So again, it's a rich database that teaches us potentially about a broad array of topics within cardiovascular disease for African Americans, but the lessons can spill over into other populations. Now, again, we could go on and on about risk, but I want to spend a little time on another concept just to sort of stimulate your thinking and maybe get some ideas and responses from the audience. When you look at particularly the social determinants of health, and you begin to see over and over that the social, psychological, physical environment clearly has some impact on health status. And you consider the African American, again, experience, if you will, in the United States, you have to ask yourself a couple of questions. Okay, so we see that some of these things are tied to high levels of blood pressure. Yet 45 to 50% of African Americans don't have high blood pressure. How do they manage that? If you look at prevalent heart disease, unfortunately high rates among African Americans, but 85% of African Americans do not have cardiovascular disease. Despite fairly adverse conditions, I think a lot of you would agree, that they confront as a group on an ongoing basis. And if you look at the oldest Americans, 85 and above, you look at CDC data, what you'll see is that life expectancy, once African Americans as a group, once they reach 85, actually tends to exceed that of whites. It's at least as good, right? Maybe longer. The trick, of course, is getting to 85. But my point is that there's clear evidence that we have to do a better job of engaging the concept of heterogeneity, that blacks aren't all one thing, that they're not all having the same experience, that backgrounds differ, and that matters. Black can't be represented in some regression as a yes or a no, and that give you some insight into black health. We've got to look a little bit deeper. So my point then is resilience is an understudied and underappreciated concept that by comparing large groups one to another, the components and the contributors to resilience get obscured, and that resilience has multiple dimensions. Okay, this is just to remind you that, you know, it'll sound like a cliche, but all blacks are not alike. And when we look at the concept of resilience, the many dimensions I alluded to can be on a community population level or individual level, and there are subcategories within those, obviously. It gets to be a fairly multi-layered concept. But in community, you can have neighborhood environment as one major component of, I mean, people live in a community, live in a neighborhood. What's that neighborhood like? What deprivations does that particular neighborhood struggle under? What assets does that community have? I mean, is there social cohesion, or is there social division? Safety of the neighborhood. Obviously, things like exercise and so on depend on having a safe environment to do that. That is a clearly important component when we consider how people live their lives and how that might impinge upon their health. Segregation of neighborhoods is still quite profound in the United States. It has a long history, and it has only in recent years begun to erode, and it's surprising when you look at the data just how segregated America remains in terms of its neighborhoods. Atlanta is actually one of the better places in the United States when it comes to breaking down some of that. But even in Atlanta, you can see distinctly black neighborhoods, distinctly white, and with very little crossover. Food sources within those neighborhoods. Individual level factors, such as what the American Heart Association has popularized as Life Simple 7 and what they call the health factors. Those things are important on an individual level. And then you can consider, and this is not meant to be exhaustive, but just for your consideration, psychosocial components, variables that can impinge on resilience, how people do in adverse circumstances, what their physiology, how the physiology responds positively or negatively. And that can be modulated, and there's a lot of literature to suggest that this is true, that levels of social support are important. Optimism is a positive feature of one's way of viewing life. Mastery of some skill or skill set, purpose in life, even spirituality. All of these things have been put forward as potential elements worthy of further scientific investigation as being protective buffers against some of the potentially adverse conditions that people live their lives in. Further to the point of heterogeneity, this is Atlas. I think most of you have seen data like this. And what it attempts to show is by color coding where the hot spots of, in this case, heart disease deaths are. I put this up to, again, to make the point about heterogeneity. These are all African American populations. And you see how vastly different in these different counties these rates are. There's a tenfold difference between the darkest, what is that, brown or red. My wife would have a better name for that color, but that color versus that. And so, but they're all African American. Again, there's a vast heterogeneity, and there are obviously people who are doing well, even a whole population, whole counties that have low rates. We don't know enough about that. This is back to the point of some local environmental features may be important. This just talked about in the Jackson area, the concentration of fast food restaurants and its relationship to weight, and there was a positive association with that. Life Simple 7, just to review, there are these 7 things for physical components, 3 behavioral, and there's the list for your review. And if you look at Jackson Heart Study data, you see, unfortunately, that very few people have a lot of the health factors, those positive factors. So the number of people who have all of them, well, I don't think we had anybody who had all 7 factors down. Most people were in the 2 and 3 categories. And the older you are, generally speaking, the worse your profile. And we talked about the psychosocial dynamic, and this gives you a sense of all the testing that was done in the Jackson Heart Study. So we looked at depression scale, stress, religion, violence in the neighborhood, talked about discrimination, optimism, job strain, to name a few. And that gives us data that can help us relate hard outcomes, coronary calcium, mortality, hospitalizations, heart failure, all those hard outcomes to a variety of variables that are in the psychosocial realm. And just to tease you with one preliminary result, looking at the notion of spirituality and blood pressure. No, that's not blood pressure, this is cortisol. And what you see is that people who experience, I think the instrument called it experiencing the divine, if you will. They did that in order not to be overly specific and say, you know, attending church or a mosque or temple. They said experiencing the divine, okay? Prayer, meditation, whatever mechanism, if you will. And so the people who said nearly every day had clearly lower cortisols, and the people who were, I guess, the heathens over here, who said not at all, had significantly higher levels. Now that falls far short of proof of a lot, but it shows an interesting finding worthy of further explanation. And so how does all of this that's in the social environment get under the skin and really cause disease? And looking mechanistically, we're interested in this, and we're proposing with Dr. Kayumi and others to take a closer look at some of these aspects of molecular resilience, if you will, by studying the epigenetics and studies that look at metabolomic signatures that might both reflect for us what the internal components of resilience might be, and also give us fingerprints to look at after intervention to see what things, when people improve, actually change on a molecular basis. So, the Jackson Heart Study, a local, ethnically restricted, if you will, Southern study. I think it's important to remember the lesson of Framingham, that is, another local, ethnically restricted study, and that we look in depth at these data, of which I've given you only a teaser today, that lying within that database may be some new, fresh insights about not just race and risk, but also resilience. I'll end my comments there and invite any questions.
Thanks, Herman. That was great. I'll start you out with one question. So is it time for a new population study? Is it time for one that's balanced and, you know, geographically and, you know, racially and et cetera?
Mm-hmm.
You know, are we, or in this current environment of funding? I know Framingham taking some big cuts, et cetera. You know, and Jackson too, are we past that? Or should we reboot and rethink and try to do the right population study?
Right. Thank you for that question, that leading question. Of course, I would love to see Jackson go on forever and Framingham and get more money. I think there is value to that. Let me start first with the comparison studies. Now, we do have studies like MESA, which is the multi-ethnic study of atherosclerosis. And even Eric attempted that as well by having 4 cities. But just about all the African Americans in Eric were all from Jackson. So there are limitations to that as well. But let me first sound a strong note for the value of an all African American study. And it's this, it's the whole heterogeneity thing. Because all too often studies that have historically been multi-ethnic have either added on or brought in African Americans as somewhat of an afterthought. The diversity within the African Americans is an important issue that again gets obscured when the point is comparing white versus black. Understanding resilience within the African American population may actually be a very important step towards resolving disparities. Why? Because obviously there is a way to live life. There are elements in both personal behavior, the environment, and perhaps in our biologies that actually favor black survival. Remember the black octogenarians, right? They live at least as long and maybe longer. What is going on there? We have to have enough of a focused look at African Americans if we're going to improve the health of African Americans and resolve disparities. So I think there's still value for that type of focused and comprehensive approach. But if you're going to talk about disparities within a region, I think a black-white comparison within the southern region is something that has not been done, except for Evans County. And some of you may remember Evans County, done in the 60s, motivated by this interesting fact. Dr. Hames, an internist in Evans County, was astounded by the fact that so few blacks had heart attacks. He wanted to know what was going on. Sort of why were they resilient in a way? And ultimately, there are lots of theories as to why. But ultimately, they recognized that one issue with the study was that in many ways you were comparing black sharecroppers living very physically demanding lives to white shop owners. So you had a big socioeconomic gap. And the types of things, the access to excess, one of my friends likes to say, the access to excess was very prominent among whites and much less so among blacks, who were also having a highly physically active lifestyle. That's a long answer.
Some other questions?
Very interesting, informative talk. Thank you. The question, if it does exist, and maybe you alluded to it when you said that obesity was less toxic for the African Americans. How about the obesity paradox? Have anybody taken a chance to look at that? One, of course, you can always question, does it really exist? But then,
Yeah.
if it does exist, is it more prevalent in the African Americans?
Now, give me more. The obesity paradox, you mean?
Well, what you tell a group of people that are overweight and obese, and they tend to come out doing better after, say, cardiac surgery and coronary disease.
Yeah, I don't have a good answer for you there. I think certainly in more advanced ages, frailty and low weight are tied, and those people don't do as well with major interventions. And I think it's true for people who are on dialysis as well. People who are in an age in life of the lifespan, like advanced, 70s, 80s, and so forth. If they are really underweight, they are more prone to have problems out of things like surgery. And the low weight may actually be somewhat tied to their overall health condition. That is, these people may be not thriving for other reasons. But I don't really have a strong answer for you.
Herman, that's very nice. Listen, have you learned anything about you didn't mention anything about accessibility to health care.
Right.
I guess my question is very simply, do doctors matter? I mean, is there anything that we can, does our health care system, in Jackson, you mentioned 8 hospitals, so
Right.
people were,
Right.
we have situation in Georgia where we have counties with no doctors, for instance. Is there any difference between urban and rural that you can
Right.
tease out?
Well, thank you for that question. It's a very important one. And I think doctors do matter. Access to care is critically important because while we focus a lot on risk and prevention in the Jackson Heart Study, once you get something, you need to be taken care of. The distribution of physicians in Mississippi does not match the patterns of disease. There are people in the rural areas who are experiencing some very difficult circumstances when they get sick. There are many efforts afoot to try and address that, but still we have a very long way to go. So doctors do matter. I think the other thing to keep in mind is that's obviously not the whole story. If you look back at things like the veterans system and access to coronary bypass surgery, when everybody in the system has essentially the same coverage, the same opportunities, the African American group tended to have significantly lower rates of bypass surgery for this with similar categories of indications, prevascular disease, left ventricular dysfunction, whatever. And that kind of difference persists. What are the elements of that? Some of them, at first we thought, it was widely thought, that African Americans were less trusting of invasive procedures, high-tech procedures, and so forth. That doesn't seem to bear out. There does seem to be some impact of that. The level of trust between the African American patient and a system that he may not have been, or he or she may not have been well engaged with before facing the major invasive procedure or surgery. So all that to say, part of the issue is access. Another part is how do we bridge the gap of not only trust, but knowledge, health literacy between the patients who are at substantial risk and the healthcare system.
So I think in recent years, the first time I thought about the term resilience was when I went to a conference on campus that had to do with multiple disciplines, and I heard a psychologist, Marshall Duke, who has worked with children who've had psychological problems, and where he's looked at why are some children resilient, why are others not. And it turned out that children who knew their history and where there was storytelling at the dinner table or in the car, and who knew about their grandparents and a variety of things, and whether that was a negative history or a positive history, it didn't seem to matter that much, but that they felt a connection with others, and they were not the ones who were the first to experience, something that came in, and it's like, wow, I'm the only one, and how they dealt with that. And as I thought about that, I thought as I left it thinking about health issues and how we cope with health issues and how we take on how we approach those, whether it be approaching it from a victim standpoint and we're going to take a positive approach, or how we do that. And I'm just so I was very interested in the title of your talk today, but these psychological components of resilience, how are those being looked at within your study?
Right. So I think that's a very important observation, and that particular story opens up several avenues of explanation, right? The kind of family where that type of talking is going on, okay, is probably a fairly cohesive, supportive family. So there's that whole element that people have talked about in terms of social support being quite salutary. Having people understand historical struggles, I think, is important. And it may give them a reference point, about their situation, and maybe give them that optimism that things actually can turn out okay. Resilience as a concept is really, in medical terms, really rooted in the psychological literature. And it really comes out of this observation that some kids facing childhood trauma actually grow up and turn out all right, whereas others deteriorate and never recover. How do people deal with what are adverse circumstances in the environment? And I think some people are clearly successful, and we need to understand as much about them and their success as we do understand about the failure of others.
Well, with that, well, thank you very much for a fantastic talk.
Thank you. Thanks for the invitation.
It's great.
The preceding program is copyrighted by Emory University.